Okay, thanks very much for coming to have a listen to this little chat. Basically, I'm going to talk to you about what I see as a transatlantic view of Vista across the ocean, of the common ground between the UK and the US open source efforts, and the challenges and the gap between us. And I'm talking as a doctor, an emergency physician, a CMIO in Leeds, and also director of my own company based in Dublin. Okay, so the points I wanted to get across are that healthcare change is a complex beast. The NHS and the VA in the US are at the forefront of leading that change. They've both identified open source as key to the change going forward, which marks them out as leaders, if you like. The issue is, though, that those of us who believe in open source are a small group at the moment, so we're a small faction here, and we know it's right, but there are challenges to making this work, and there are opportunities too, but what we need to look for is how to make some steps forward to join up the efforts. Okay, so the first point to begin with is that healthcare systems around the world are kind of acknowledged as being under pressure or broken in some places. The NHS, although it's a great system, is talked about in broken terms sometimes. The US system equally defined as broken. The Irish, the Australian, most Western countries are struggling. They're really struggling to deliver healthcare. And part of that is because of the complexity of healthcare. It's a major system, it's a complex adaptive system, it's a difficult system to change and improve. And those systems that understand how to do this properly understand that this isn't changing a machine, it's changing an ecosystem. It's about understanding healthcare as an ecosystem and trying to influence change within that environment. So here's the NHS in the UK, and most of us who work here are familiar with that. The quotes there are from Don Berwick, who's a leader in the US healthcare movement, who acknowledges the NHS as a great exemplar of healthcare worldwide. And you know, I came to the NHS originally because it's a very proud ethos that underpins the NHS around free care at the point of delivery. Equally, in the US, amidst the difficult, let's say, landscape of the US healthcare setting, which it is a mess in equal places, you have the Veterans Administration, which stands out as an exemplar of good practice and good care and evidence-based practice, and it stands out ahead of the rest of the US system. That's a good book for those of you who haven't seen it, called Best Care Anywhere, which really tells the story of how it got transformed. So there's common ground, and for those people who are of the view that care is different in the US and the UK, I'm an Irish doctor, and I've practiced in Ireland, I've practiced in the NHS, and I've practiced in the US. And the bottom line is that care at the front line is much the same. Okay, so the process can look complicated and different, but the core process of care is the same, in many ways. Part of that is that we really do share some key processes in healthcare around assessing the patient, delivering care, planning care, and also we all have pressures around managing our resources and also managing performance and budgets and research and audit and the like. And we all know that to deliver on any of these core processes, you need better health IT. And so, excuse me, I got into this because, to do that you need better information, you need better technology, and that was the driver that I got involved in some time ago. So in my time in working in Ireland, England, and the US, I've really been looking, if you like, at the market from all of those perspectives. And I think this slide, I hope, exemplifies where most people are at. So in the NHS on the left is an example of a system where, for the most part, most acute hospitals, and I use this in reasonably broad terms, but I think it's a fair point that most hospitals are made of multiple disconnected proprietary systems that do not interoperate and connect well together. So they are part of the reason why healthcare is not delivered well in this country, at least in the acute sector. It could be much better. There are lots of reasons why it's good, but there's much room for improvement. The National Programme for IT came along and talked about ripping and replacing technology with a single vendor or one or two big systems, an enterprise-wide system, and that did not go down too well. So most of us are somewhere in the middle now, trying to find a common ground around portal and integration and legacy integration and move to more service-oriented architecture. And equally, if you look at the US, this is representative of a large part of their market too. You might, if you are new to Vista, think of Vista over on the right as a big enterprise-wide system. You might, if you know anything about the DoD Alta system, think of that as another system that doesn't necessarily talk so well to the other. So interestingly, the story around the US, the VA DoD work is around trying to get Vista and Alta to work together, and how do you move them towards a common services-oriented architecture. So most places in the world are somewhere in and around this movement, but most people are moving generally towards a more modular service-oriented architecture approach to building systems. And of course, we know the history of the National Programme for IT, which tried to do some of this at scale, largely using proprietary software, and it did not go down too well. You may or may not know that the VA DoD work around their joint EHR plans was also a $1 billion exercise, and it has also hit hard ground because this is complex, as I said. So both the NHS and the US are in similar places here. They're both struggling to do this properly. The key common ground, one of the key bits of common ground, though, is that both the NHS and the Veterans Administration in the US particularly have identified that open source is going to be key to making this work. It's not easy to do, but it's going to be key. And so what you have in the US under the leadership of Sung Ki-moon, who's with us today, is OSERA, which is essentially trying to oversee the refresh of Vista, because there's an acknowledgement that it needs to change and it needs to modernize. And equally, under the stewardship of Beverly and Richard Jefferson and others who are here at this conference, we have this landmark around the Safer Hospital, Safer Wards initiative, which is around saying, for the first time, if you like, that open source could be a good thing for the NHS. So for those of us who've been saying that for a while, we are very grateful for that support and that leadership at the top. So we have, if you like, both camps who are both working in a common direction here. But I say camps for a reason, because what we have equally is two different style of camps. We have, if you like, on the UK side of things, the English side of things, a very interesting and healthy mix of open source efforts that are aimed at trying to shake up the market. That people like Rob Dyke and Ward Ware, the NHS Hack Day movement, Ewan Davis's Handy Health movement, the Open Eyes effort, Open Air, not to mention our own work in Leeds. So kind of an interesting mix of all sorts who are trying to do open source, open air, or sorry, who are trying to do open source. And on the other side, at least in simple terms, what some people think of as the US approach to that is an open source effort around a big monolithic Vista. So that's the kind of thinking that some people have here, is that, you know, there are very different styles of camps and culturally, you know, not necessarily an easy fit. But the point is that we're here because we believe in healthcare change. We're here because we think open source is key. And I'm trying to make the point that we do not need to be in any way competing. We need to try to find ways to collaborate here. There'd be no point in trying to say this is an either or. So my talk today is about trying to find the common ground between us. And I think it's fair to say that those of us who are here today are of the belief, and I certainly am, that in the 21st century, if we are to really transform healthcare, all of us need a solid and robust open source platform to revolutionize the market in the UK, the US, and across the world. And that's going to happen. It's just a question of time, and it's a question of what that platform is going to be. So just a couple of challenges to throw out to both camps who are represented here today, the UK and the US camps. First of all, if you take, let's say, the NHS, or you take the US market, very few are greenfield sites anymore. There's very few places like Jordan or the like where you have a clean slate and you can just deploy this without having to worry about what's been there before. Neither do most people want an all or nothing proposition. They don't want to go down the road of the National Programme for IT and be told you have to use a single system. So we have to find a way to integrate with what's already out there. and not be pushing people onto a single solution. It won't look good or work well if we do that. Okay, the second is around the code and the community around code. So we have an issue with both of those camps that I mentioned using different code bases, different types of code. So we have the web-based camp, which are largely the UK groups that I've mentioned. You have a mumps, or what is understood as a mumps-based camp in Vista, and mumps is not well understood here at all, so it makes people frightened. And so we have two different communities. We don't have enough common community there, and we need to try to address that. We also have an issue, and I mentioned this at a presentation I was doing yesterday around particularly the secondary care market. We have an issue with usability of systems at the front line. And when you're showing systems to frontline clinicians, they don't care about the underpinning architecture, they don't care about the underpinning code base, they don't care about whether it's open source or not. What they care about is whether it looks good and it works well. So I'm of the view that if we want to do this properly, we need to make our open source framework the best in class at the front end so that it looks great. And people shouldn't be in any way ashamed of it. Now CPRS, where Vista is at the moment, I think has got work to do in that space. I don't think it's as good as it could be, but I know it's well liked. Equally, there's a move towards web and mobile that we have to embrace, because that's the way the rest of the world and the industry is going, so we need to tackle that. And so those are some of the key challenges we got to address. Okay, so let me move on now to opportunities and reflect back that equally that issue that I've just mentioned, while a challenge is also an opportunity. So we have got in the NHS, for those people who are trying to bridge this gap, a set of common user interface standards for the UI. We have a set of RCP headings for Royal College of Physicians that would look great in an open source platform. They just aren't there yet, and we need that for people like myself to engage clinicians and try to get them to understand the potential on offer here. So that's the first opportunity that I think we could look to work together on. There is opportunity number 2 at the service layer. So getting technical a little bit for a moment. Both camps that I mentioned are aware and understand the importance of not just the front end and the architecture around that, but the middle tier. So web services is the way most people understand that we need to embrace. We just have to be willing to open up a platform that's open source, that offers a variety of web services, and work has gone on, certainly in the US here on Meadows, which is the work that's been done by the VA. The VSA is a new approach to that. Work has been done in SMART, in Harvard, and what we're doing, particularly in Leeds, is trying to work on the idea of a set of open NHS APIs. So what we're talking about is some common middleware web services that would be good. Again, not just because it's the way to build systems properly, but also that it could provide those hackers and the Hack Day movement, the Handy Health movement, and all the other people who want to engage on this, a platform that they can work against. And there isn't such a platform out there yet, but it is needed if we want to really transform this market. Okay, and opportunity number 3 then. So just to reinforce, so the point here is that we can work together on this. The third point is that persistence is the word I use, but what we have is a challenge with the scale of big data in healthcare. So there is an excellent case, if you look at this and you try to understand this, that the power of mumps, which underpins not just the VA success, but Kaiser's success, is partly about the language, but it's mostly about the power of mumps as a database, as perhaps the ideal fit for healthcare data. But that has not been well explained and is not well understood, certainly in the NHS market. Equally, if you try to look under the hood of mumps or Vista, and you try to understand the clinical models that are there, the clinical models are very difficult to dissect out for the uninitiated. And the UK, the Europeans, the Australians are ahead in that. If you look at the work that's been done on the archetype approach, which again is not understood in the US sphere. So there are two elements here that need to be looked at together. And I think there's a very good fit here potentially. It's just that most of the camps haven't looked at the potential common ground here. But I think there's a potentially very interesting piece of work on the challenge of healthcare data persistence. Okay, so again, I wanted to talk about, frame this as transatlantic, because you can take the view that this is transatlantic because there's a big gulf between the camps, and so life is difficult to try to bridge that gap. Or you can take the view that actually that's not a problem at all, because I'm from Ireland and I'm trying to, an Irishman, you tend to look both ways. You tend to look at the US and the UK and see the common ground. So I've looked for the common ground, and I have tried to identify where I think there's a very good fit. And I need to draw your attention to the work of one gent who's sitting here in the front row, Rob Tweed, who is UK based. He's an Irishman, but he's UK based, and he has essentially got some very interesting work that he's already done that is pretty well understood, or increasingly well understood in the US Vista world, but is very much or not well understood or appreciated in the UK market. But he's done work in these areas around user interface, the web. He's done work on the middle tier and web services from Vista, and he's done a great paper which I draw your attention to, perhaps his best paper, on the power of MUMPS as a universal engine for data in healthcare. And so there I think is the beginning, a seed of some common ground. And so just to give you an idea of how I talked about the transatlantic gap, so what I was trying to do was try to find out how to bridge that gap. So for 10 days, I took on a project with Chris Casey, who's also here today, works with Rob, where I led a project with Chris, and over 10 days we did a project that was using JavaScript and MUMPS and the stack that is used by the Vista, some of the Vista community in the US, the World Vista and the Orville camps, and we tried to see what we could do. And we didn't meet, we never physically met. We did this on Skype, we did this on email, we did this by phone, and we did this in a way that shows what you can do just when you put your mind to it. So what we did in 10 days was we did a prototype of a clinical application using web-based technology, but is also based on MUMPS, the Vista platform. And it showed me, it certainly reinforced to me, and there's the website if you ever want to have any further look at it, that there's immense potential on offer here if we just put our minds to it. And so I'm in the midst of trying to progress that work to another stage with Rob and Chris. Okay, so I'm going to begin to close now and say that what we are all here for is that we believe in open source, we believe in healthcare needs to change, we need open source as part of that change. I use this diagram to explain an ecosystem that is around the world where people are trying to do the same thing. They're reinventing little triangles of effort, from an international effort to a national effort to regional effort to local effort, but all the efforts are pretty similar. The difficulty is we're not well joined up at the moment, and we need to bridge those gaps. So be you a frontline innovator, be you a vendor, we need a grassroots movement that is joined up across the ocean with the stewardship of perhaps Osera. I mean, Sonki's here for this, to say how could we begin to try to have some of the reasonable governance around this. But either way, we need to get some work going together between us, and we need to try to show that as a small but cohesive group that we can deliver something useful, not just for the NHS or the UK or the NHS, or sorry, the VA, but across that divide. So I'm going to close there to say this is a challenge that is complex. Both the NHS and the VA are in an interesting position, acknowledging open source. There are challenges, there are opportunities. I think there are already some simple steps we can take to move us forward, but I would welcome your effort and your help in doing so. Thank you very much.